Welcome to the Workplace Minute, powered by H3HR Advisors and sponsored by WorkHuman. Thanks for joining me for your quick update on what's important in the world of work. My name is Steve Boese. This week on the Workplace Minute, we are revisiting 3 workplace issues that once dominated the conversation, but have received less attention more recently. They may have moved out of the headlines, but they've not gone away. In many cases, the early predictions, promises, and controversies have now given way to harder questions about costs, access, implementation, and who ultimately benefits. We begin with GLP-1 medications, which have rapidly progressed from a healthcare innovation and cultural phenomenon into one of the most difficult financial and strategic decisions facing employer-sponsored health plans. Drugs such as Ozempic, Wegovy, and Zepbound were initially discussed primarily in terms of their ability to produce substantial weight loss, but the conversation is now much larger. GLP-1 medications are being used to treat diabetes and obesity, and some have received additional approvals connected to cardiovascular risk and obstructive sleep apnea. Wegovy, for example, is approved to reduce the risk of cardiovascular death, heart attack, and stroke in certain adults with cardiovascular disease and who are overweight. Zepbound is approved for chronic weight management and for moderate to severe obstructive sleep apnea in adults with obesity. That widening clinical value has strengthened the argument that these drugs should not be treated as optional lifestyle benefits. But it's also expanded the number of people who may qualify for them, just as employers are confronting some of the fastest healthcare cost growth they've experienced in years. According to Mercer, the average cost of employer-sponsored healthcare reached $17,496 per employee in 2025, an increase of 6%. Employers projected another 6.7% increase for 2026, the largest expected increase in 15 years. And prescription drug spending among large employers increased by an average of 9.4% in 2025, with growing GLP-1 utilization identified as an important contributor. That helps explain why GLP-1 coverage can be expanded, and in some cases, though, it's tightening, and in some cases, it's being eliminated. Coverage estimates vary significantly because surveys examine different employer populations. Mercer found that 49% of large employers covered GLP-1 medications for weight loss in 2025, up from 44% in 2024. And a broader employer survey released in July of 2026 found that 36% covered the drugs for both diabetes and weight loss, while another 60% covered them for diabetes only. Among the predominantly very large employers surveyed by the Business Group on Health, 67% currently cover GLP-1 drugs for weight management, but nearly 8 in 10 said the medications were increasing their healthcare costs, and only 72% of employers currently offering weight loss coverage said they were likely to continue it in 2027, and 10% said they were likely to discontinue the coverage. So the broad direction is not a simple march towards universal coverage. Employers are trying to preserve some access while reducing the financial exposure created by a potentially large eligible population taking expensive medications for long periods of time. That increasingly means coverage with conditions. Employees may be required to meet specific body mass index thresholds, document an obesity-related medical condition, obtain prior authorization, first attempt lower-cost interventions, participate in a weight management program, or receive prescriptions through designated providers. Some employers are requiring ongoing weigh-ins, nutrition tracking, or participation in virtual health coaching as a condition of continued coverage. So on one level, these requirements reflect legitimate efforts to ensure appropriate prescribing and improve participant results. These medications are generally intended to be used alongside nutrition, physical activity, and clinical monitoring. Employers also want evidence that a high-cost treatment is delivering meaningful health improvement. But the requirements can create another layer of administrative friction between workers and medically prescribed care. An employee technically may have GLP-1 coverage and still encounter repeated authorization requests, narrowing eligibility standards, mandatory programs, or the threat that coverage could simply disappear during the next benefits year. And that uncertainty is especially consequential because obesity is a chronic condition, and patients frequently need to remain on medication to maintain the benefits. Coverage that lasts for only a year or two may leave workers facing the choice of paying hundreds of dollars each month, switching treatments, or just stopping entirely. Some self-pay options for these drugs have improved, but they have not eliminated the affordability problem. Lilly currently advertises Zepbound self-pay options beginning at $299 per month for the starting dose, with higher doses costing more. Novo Nordisk has also introduced lower direct pay prices for some Wegovy doses. Those programs can make the drugs substantially less expensive than their traditional list prices, but even $300 to $700 each month remains beyond the reach of most workers. The offers that also come with eligibility rules, and they can be changed and even withdrawn by the manufacturers. And that raises an important workplace equity question. When an employer excludes GLP-1 coverage, it does not necessarily prevent employees from obtaining the drugs. It may instead divide access according to who can afford several $1,000s per year in out-of-pocket spending. Higher paid employees may be able to continue treatment through direct pay programs, while lower paid employees with the same medical needs cannot. It is a healthcare innovation with potentially significant benefits that may be most accessible to the people who already have the greatest financial resources. Employers also have to consider what they are comparing the cost of treatment against. Obesity is associated with diabetes, cardiovascular disease, sleep apnea, joint problems, and other costly conditions. The financial case for coverage is therefore based partly on whether paying for GLP-1 medications today can reduce future medical claims, disability, absenteeism, and other costs. But those long-term savings are difficult for an individual employer to capture. Workers change jobs, health plans change vendors. Employers may pay for treatment now, while another organization benefits from improved health of an employee several years later. That structural reality encourages employers to focus on the immediate pharmacy expense rather than the broader lifetime value of treatment. There's also not yet a single definitive answer showing that broad GLP-1 coverage will consistently pay for itself within the time frame employers use to manage annual health plan budgets. So for benefit leaders, that makes the decision much harder than simply acknowledging that the medications usually work. For workers, however, the issue is much more personal. Coverage can determine whether someone can begin treatment, whether they can continue it, and whether a major improvement in their health remains financially sustainable. Research is also beginning to suggest that eliminating coverage can influence how employees view the organization. A 2026 study of healthcare employees who lost GLP-1 obesity medication coverage found worsening perceptions of the employer, feelings of being devalued, greater burnout, and increased consideration of changing jobs. Now, this study was relatively small and should not be generalized to every workforce, but it illustrates that employees may view the removal of coverage as more than a routine plan design adjustment. This is why GLP-1 coverage has become such an important benefit strategy issue. Employers can't ignore the cost, but they also should not treat obesity care as a cosmetic perk or make decisions based only on the next year's pharmacy budget. They need a clear philosophy about clinical eligibility, employee affordability, the evidence required to continue treatment, and how coverage decisions will be communicated. And they should also examine whether their cost management requirements actually support better care or simply create enough friction to discourage employees from using the benefits. GLP-1 medications have moved well beyond the initial excitement surrounding rapid weight loss. They now sit at the intersection of medical innovation, chronic disease management, employee expectations, health equity, and employer cost control. And the question is not simply whether employers should cover the drugs. It's whether they can design coverage that's clinically responsible, financially sustainable, and dependable for the workers whose health have come to rely on it. And we expect that this will be one of the defining employee benefits challenges for the next several years at least. A big thank you to WorkHuman for supporting the Workplace Minute. Be sure to subscribe to the HR Happy Hour Network on YouTube or wherever you get your podcasts. I'm Steve Boese, and this has been the Workplace Minute from H3 HR Advisors.